Start.
Well, ladies and gentlemen, good morning to this first of the sessions this morning, which is on respiratory health. And really, it is addressing the key issue that we're facing, which is life course perspective to respiratory health trajectory. We have really exciting speakers, really exciting topics. Please do post all of your questions and into a chat box, and we will answer them as we go. Really, I would like to go straight to the presentations to make sure that we get the most out of the speakers that we currently have. And the first speaker doesn't need introduction, SEJAL SAGLANI from Imperial College, my close colleague and collaborator. SEJAL is going to be talking about very, very important topic, which is what about microbes as novel targets for asthma treatment and prevention. Over to you, SEJAL.
Perfect. Thanks very much, Adnan. Thanks for the invitation. So we're going to talk about what role microbes will play in both asthma treatment, but also prevention. And when we think about the development of asthma, I think most of us will have seen this data from the Tucson cohort, which followed children with wheezing from early life through to adolescence and adulthood, and showed us that there were sort of phenotypes, clinical phenotypes of wheezing, one of which was the viral wheeze phenotype. So already there was some idea that pathogens are important in the context of wheezing and asthma. But really what we want to know is, are these viral infections important later in life? Do they determine the development of asthma, or actually, because the children grow out of their symptoms, are these no problem at all, and is it all completely benign? Well, if we look at the lung function data that goes with the data from Tucson, I think you'll appreciate that it's probably not that benign, because the persistent wheezers who go on to get asthma start off with normal lung function, and the transient wheezers, who we all believe are viral wheezers, they're going to grow out of their symptoms, everything's going to be fine. Although they're born with abnormal lung function and they have some catch-up, actually look exactly like persistent wheezers from the point of view of lung function by the age of 6, and they look exactly like each other in adolescence. So it doesn't matter how you started, what caused your wheezing, and even if you grew out of the symptoms, from the point of view of lung function, that abnormality is still present in adolescence. And I'm sure Adnan will be showing you data later, even beyond adolescence. And so this data really explains that your disease activity from childhood to adulthood, whether it's persistent and the symptoms carry on, or even if, for the light blue line here, your symptoms may remit, they could easily come back in adulthood and are probably going to be associated with a background of continuous abnormal lung function. So what's going on, and how can we prevent this? And what's the role of microbes in any prevention? Well, if we think about the development of asthma, what we know is, in a susceptible host, although they may have a normal healthy airway wall, if they're susceptible and to an environmental illness, insult like allergen, infection, or pollution, they'll have the parallel development of inflammation in the airways and development of airway remodeling to result in an airway wall that looks like this, which is an asthmatic airway wall, with marked structural changes in the airways and a lot of eosinophilic inflammation. But how soon does this begin? How early do these abnormalities begin? Well, I think I'll convince you that they begin really quite early. If we look in the airways of children at about a year of age, they don't have much in the way of eosinophilic inflammation or remodeling. But already by the age of 3, wheezers have both eosinophilia in their airways and remodeling. So the changes are starting really, really early in life, in the first 5 years of life. But what's causing the changes, and how can we stop them? Well, to try and understand this, we need to look at the risk factors that determine asthma. And one of the most reproducible and robust risk factors that determines development of asthma is early allergic sensitization. And if we look at all preschool wheezers and split them into those who are atopic or allergic and non-atopic, it's actually the allergic ones that tend to have the majority of eosinophils in their airways. But why? This is all association. I've shown you association between lung function and pathology, between allergy and pathology, but why and what's causing this? Well, to answer the causation question, we have to go to preclinical models. We can't do mechanistic studies in young children. So what we did here was we gave mice of different ages their first ever exposure to allergen. So either in infancy, which is the 3-day-old mice, in childhood and adolescence, 15-day-old mice, or adulthood. That's the first age that they got their allergen exposure. And what we found was really quite amazing. The 3-day-old mice had markedly increased lung eosinophils, airway eosinophils, markedly worse lung function in the form of airway hyperresponsiveness, and a marked increase in the Th2 cytokines, interleukin-5 and 13, that drive this, this immunity, allergic sensitization, and the features that we see in asthma. So why are these young mice having such a dramatically exaggerated response? Well, it's not because they haven't got any immunity, because if you look at the T regulatory cells, the cells that are supposed to stop that skewing, type 2 skewing, they're definitely there at 8 days of age in the lungs. But what's really interesting is if you look in the airways of the mice and the microbiome of the airways of the mice, then the bacterial load is significantly lower in the early neonatal infant mice. And as you can see, the makeup of the microbiome is very, very different. It's far less diverse in early life, and it becomes much more diverse with a significantly increased bacterial load as the mice get older. And that change in the microbiome has a direct impact on immunity, whereby the T regulatory cells, which are predominantly Helios positive in early life, become a much more Helios negative and protect from eosinophilia and airway hyperresponsiveness. So now we've got some real data showing us why in early life there's such a susceptibility to type 2 skewing, and perhaps it's because of the makeup of the microbes in the airways. Well, that's all well and good because that's mice, and you're thinking, well, how does that even relate to children? Well, I think I'll convince you it does, because some of the most reproducible data that we have of protection from asthma in cohort studies is living on a farm is significantly protective from the development of asthma and allergies. And this study really, really highlights that. It was a study done in North America amongst the Amish and Hutterite communities. And although they have a similar genetic background and a similar lifestyle, the one thing that differentiates them is the way they do their farming and agricultural practice. The Amish practice traditional farming, the Hutterites modern industrialized farming. The Amish have a really low prevalence of asthma, the Hutterites exactly the same as the indigenous North American population. Really interesting. Why? Well, if you look at the composure of the dust in the households of these families, the Amish homes have significantly increased endotoxin. And what is endotoxin found in? It's found in microbes, a big component of microbes. And the Amish also have significantly fewer eosinophils. And I've just shown you that the older mice that don't get the eosinophilic inflammation have fewer eosinophils. So that's interesting. So now what happens if we use our early life mouse model and not just give allergen, but we also now give microbes. And the microbes that we've given are the ones that are found in the protective farmyard environment. And here we used Acinetobacter ewophi, a specific microbe found in the farmyard environment. And when we give the mice both allergen and Acinetobacter ewophi, the eosinophils have essentially gone, the airway hyperresponsiveness completely resolved, level of the type 2 mediator 13 is lower, and the cells that are producing the IL-13, CD4 positive T lymphocytes are significantly lower. That's important. The CD4 IL-13 positive lymphocytes being reduced is lower because we think that's the mechanism responsible for this protection from the point of view of immune responses. So this is now getting exciting because it's telling us that actually microbes may be really important in the prevention of asthma. But the majority of our children that give us a real pain and present to us again and again and again with wheezing are actually getting wheezing because of viral infections. the majority of preschoolers and children that get asthma are not sensitized early. The majority are just getting viral infections. So how is this protection relevant to viral wheezers? Well, I think there is some relevance here, because what we know, again, from big cohort studies, is there's a certain genetic susceptibility to rhinovirus wheezing, and the children that have that genetic susceptibility and get rhinovirus wheezing are much more likely to have asthma. So if you have a SNP in your 17q21 chromosome and you have at least or more than one rhinovirus wheezing illness, you're much more likely to have asthma. And this has been reproduced. This is a completely separate cohort and the data look identical. On the right, we've got a Danish and American cohort. On the left, a German cohort. So definitely something about susceptibility, rhinovirus wheezing, and asthma. Why is that relevant to microbes? Well, if you take those children with that genetic susceptibility with rhinovirus wheezing to develop asthma, and you put those same susceptible children into an environment with animals, so the dotted line, susceptibility, that prevalence of asthma is significantly reduced. The probability of wheezing, as you can see, significantly induced. So even though they had the genetic susceptibility and in a different environment got lots of rhinovirus wheezing illnesses and asthma, you put them in an animal shed environment and they're protected. So this is telling us that perhaps even viral wheezing is associated with microbial composition in the airways. Another virus that definitely is associated with significant recurrent wheezing and asthma is RSV. And the more severe and more recurrent infections you get, the more likely you are to get asthma. So again, now to show causation, we've generated an early life mouse model of recurrent RSV infection. And we give mice a first infection at 5 days of age and a second infection at 15 days, which would be older school age adolescents. And the mice that have recurrent RSV have a lot of lung eosinophils, and they have a lot of these CD4 T lymphocytes. But what happens if we, the other types of cytokines that are increased are IL-5, which causes the eosinophilia, and IL-13, which causes increased mucus in the airways, which is what we see in our patients with recurrent wheezing that keep presenting. But the thing is, the cells that are increased are the ones that were affected in the house dust mite model, and we gave them microbes to prevent it. It's the CD4 positive, 13 positive cells that are increased in this model. So what happens now if we give those microbes in an RSV viral wheezing model? The eosinophils go down, the CD4 cells that produce 13 go down, and the mucus is completely gone. So this is getting really exciting because we've got a way of microbial manipulation that not only reduces allergen-induced airways disease, but also viral-induced wheezing and airways disease. So I hope I've convinced you that in the context of prevention of asthma, microbes are becoming really important and center field. And the evidence that it's not just all in mice and it's relevant to children is that this clinical trial is currently ongoing, which is using oral mixed bacterial lysates in really early life in children, in infants. They're being given this bronchovaxum oral mixed bacterial lysates for 10 days each month for 2 years, and then they'll be followed for 3 years. And the primary outcome is time to first wheezing episodes. So can we achieve, for the first time, asthma prevention by microbial manipulation? Really, really interesting and really, really important to understand this. The thing to bear in mind is this trial is using oral exposure, and the data I've shown you in the mouse model was inhaled. But there's a definite link between the gut and the lung microbiome. And in real life, children, when they're very young and they're in those farm sheds, they're going to be on the floor, they're crawling around, they're putting their hands in their mouth, and they're breathing the microbes in. So perhaps the gut microbes are just as important to affect the lung microbes, although our current sort of mechanistic data suggests inhaled microbes and the lung microbes are really, really important. But what about the importance of microbes in the treatment of asthma? That was the other thing I was told to discuss. Well, this is data from children who have already got wheezing. It's too late to prevent it. They've got established wheezing. We've looked in their lower airways to look at the inflammation. And if you look in an unbiased way, there are 3 big clusters. Now, ignore the green cluster, they're older children, school-age children. But the red cluster are preschool severe wheezers who have got allergic sensitization, they're eosinophilic, and they respond to steroids. But there's this second cluster that's really interesting. They're preschoolers, but their airways are predominantly neutrophilic and they don't respond to steroids. So what's this cluster about, and how do we treat them for a start, and what's causing the neutrophilia? Well, if we look in a bit more detail at the children with severe wheezing, regardless of atopic status, what we find is at least 50% tend to have bacterial infection by traditional culture in their airways, even when they're well, not during an attack, even when they're well. And the ones that have the bacterial infection have increased neutrophils. So maybe that neutrophilic cluster are steroid refractory because actually the neutrophils are associated with certainly infection. And that's probably why they're not responding to steroids, because it could be the infection that's driving the neutrophilia. And if you look for the bacteria, what's causing the bacterial infection? There are 3 bacteria that absolutely predominate repeatedly: Moraxella catarrhalis, Haemophilus influenzae, and Streptococcus pneumoniae, accounting for the majority of the bacterial infections in these children. And especially in wheezers, Moraxella seems to be really, really important. And when we look at these wheezers in an unbiased way, using the microbiome, again, we find 2 microbial clusters: a Moraxella predominant cluster and a mixed microbial cluster. And what's really interesting is the Moraxella predominant cluster have the most neutrophils, and the abundance of Moraxella is associated with numbers of neutrophils, suggesting that it's the infection driving the neutrophilia. And maybe if we treat the infection, so again, microbes causing the symptoms, causing the disease, if we treat the infection, maybe we'll improve the neutrophilic inflammation. So has anybody ever done this? Well, it's not been done at all in any randomized controlled trials, but what has been done is in an observational study. This is a study from Germany where they looked in the lower airways of preschool wheezers. They found the same 3 bacteria that we found, and they found the ones with children with bacterial infection had more neutrophils, exactly what we found and what I've just shown you. But in this study, in a very observational way, the children that had the bacterial infection were treated with targeted antibiotics for anywhere between 2 and 16 weeks, the clinician decided. And what's really interesting is that the children that got the prolonged antibiotics, 12 months after the treatment, had a halving of the number of episodes of wheezing, a significant drop in the frequency of their episodes, and a lot less hospitalizations from wheezing. This is not a randomized controlled trial, but it's certainly proof of concept evidence that if we find the right patients who have bacterial infection and neutrophilia, and if we treat them with antibiotics, maybe we can impact the prevalence of wheezing. So microbes, I hope I've convinced you, are likely to be very important in the context of treatment of wheezing, just as they are in the context of prevention of wheezing and asthma. So in summary, I've hopefully told you that during health, even if you have a genetic susceptibility, if you're in an environment that is protective, i.e. a diverse microbiome, and a rural or a farmyard environment, the prevalence of asthma or the likelihood of developing asthma is much, much lower. But if you have genetic susceptibility, and if you're in an unfavorable environment, such that your microbiome is not diverse, and in fact, you might have a predominance of infection of a specific type of microbes, then you're much more likely to develop allergen sensitization, much more likely to develop asthma. And what really we want to do is prevent that progression altogether. And we're thinking more and more that perhaps microbial manipulation might be the way forward. Thanks very much.
Thanks very much, SEJAL, for absolutely fantastic talk. And while the questions are coming, could I start by asking you actually two, I think, fairly relevant questions. One will be related to the timing of intervention and another to the type of intervention. So to start with timing, obviously, as early as possible would be kind of approach that one would take based on all of the available data. But what is your opinion about intervention during pregnancy, really sort of to try to modulate the nature of innate immune responses and hopefully kind of also do something for the mother versus early neonatal? Where do you stand?
So I think at the moment, in terms of short-term ability to find the window, I think we've got really good evidence that we've got a good window if we intervene in that first, certainly before the age of 3, I would say between birth and 2 years of age. We know that when you're born, your airways don't look very abnormal. It's only as the exposure to inhalants or infection starts that the pathological abnormalities, and critically, it's that remodeling, the structural changes in the airways, they are permanent. We don't have anything to impact those. So if we can, before those changes develop, come in with an intervention in that window of opportunity, I think, which is definitely the first 3 years of life, I think we've definitely got something there that we can do. You're absolutely right. Pregnancy would be ideal, Adnan, but we don't know enough about the makeup of the amniotic fluid, the microbiome of the amniotic fluid, and what the intervention would be at the moment. We don't know enough about that. I feel much more comfortable about saying early life and what we know mechanistically. We've got interventions that we can come in with.
Also, your data that you have shown in RSV model is really, really remarkably interesting because to the best of my knowledge, is the first time this conceptual framework has been taken from, your standard allergen-induced model into what is really sort of much more relevant to human model, which is model of probably ultimately interaction between viruses and other environmental exposures.
Exactly.
Do you think mechanistic experiments at this time are actually possible to start teasing out these complex interactions that may occur between different environmental exposures?
Yeah, I think we're getting really good at making sure that the mechanistic models mimic what we see in children. We're understanding that we can't just use adult mice for every single thing, which is the big mistakes that have been made so far. People hadn't appreciated that if you don't have an appropriate model, everything you find is irrelevant, and that's a completely artificial scenario. So what we're doing is we look in the children, we know what we see in the children, and we make the model fit that, and only then would we then explore mechanistic pathways. But I do agree that having viral infection models are critical to be able to really understand, because the majority of our children and patients are the ones, they give us a nightmare and they're getting viral infections again and again and again. That has to be the way forward to understand what's going on. Yeah.
And then the questions that are obvious, which is, we kind of go from one end, like talking about diversity, microbial diversity, which clearly is critically important, to try to translate that into manageable intervention. How much the protective effect that you saw and others have been seeing for a while is related to specific bacterial strains? How much of that is related to diversity? Obviously, ongoing studies are on bacterial lysates, which have been in use for best part of 30 years. So we have, at least really solid safety data.
Safety, yeah.
How do you see this developing? Are we going to have a sort of a cocktail of molecules? How important will be the exact ratio, or is it really just about trying to find something that is going to provide this important stimulation?
Yeah, so the balance is between what's practical, and for children, usually something oral is much more practical than inhaled, although my preference would be an inhaled compound would be ideal in this scenario. But what we're looking at are the metabolites produced by the bacteria. So I don't think it's the bacteria itself that's doing much. It's either the endotoxin within it that's critical, or the metabolites that result from the interaction of the bacteria with the inflammatory cells and the airways. If we can find a way of identifying the correct metabolites and giving those in an inhaled formula, I think that would be really a really nice way of doing it. I'm not sure how the oral manipulation is going to work. I'll be completely honest, because I don't know if we understand enough about the links between the gut and the lung microbiome to really understand how much the oral gut microbiome is going to change what's going on in the lungs. That's going to be interesting.
You've really sort of raised another fascinating question. And, you know, with Erika von Mutius's work looking at nasal microbiome versus pharyngeal microbiome versus skin microbiome versus environmental microbiome, all of which obviously are not independent of each other, and all of which may impact upon slightly different aspects of a problem that we're seeing. So out of all of the data that you have, ultimately, in terms of asthma, not necessarily general immune system, do you think it is inhaled route that is really crucially important? Because obviously that touches upon the way of administering any strategy.
Yeah, so I think the inhaled route for asthma is really important, because we've got to impact the structural cells as much as we've got to impact systemic immunity. The epithelial cells and their function and the remodeling that we see is as important as anything else. And I think my feeling is if we can give something inhaled, we're likely to succeed with those structural changes much more efficiently and effectively than we will. I think we'll impact general immunity with systemic treatments, but you know, the advantage of the lung is it's exposed to the air and we can give things directly. And for me, that's the way forward. Yeah.
Thank you so much, SEJAL. It was really fascinating insight. It's also sort of proved that perhaps there is life at the end of a tunnel, and maybe
I think that's what's really exciting. Yeah.
the world without asthma is achievable. And thank you for your time. Thank you for sharing your expertise. I know that you have to go to clinic. Good luck with the rest of the day, and thanks very much for joining us here.
Thanks, Adnan. Cheers.
From asthma, we are now going to go and address another sort of really important part of care for allergic patients, which is that of food allergy. In a second talk, we will be joined by Dr. Paul Turner, who is reader in Pediatric Allergy at Imperial College London. And Paul's work over the period of last number of years has focused predominantly on the area of food allergy and anaphylaxis. In food allergy, we are again moving finally from really passive approach of avoiding the food, giving our patients advice on carrying EpiPen, to much more active approach to managing the disease. So Paul is going to talk about all of these new horizons in food allergy, particularly oral immunotherapy, as really fundamentally new approach and a new dawn in an era of management of food allergy and anaphylaxis. So Paul, if you could share your screen and join us, I'm very grateful that you rushed up from the ward down here and back again. I'm really looking forward to this. Welcome to the meeting.
Hi, thanks Adnan for the welcome. Good morning everyone, or good evening, depending on which part of the world you're at. So my task for the next sort of 20 minutes or so is to touch on some of the issues regarding oral immunotherapy, and specifically dealing with whether this is going to become the vogue for routine practice over the next sort of 5 years or so. I'm just waiting for my computer to catch up with life. Perfect. So these are my declarations of interest. There's nothing particularly relevant to this particular talk. I have been a local investigator for some commercial studies of oral immunotherapy and also epicutaneous immunotherapy, but that's not been on a paid basis, although I am a member of the advisory board for Allergenis. So the questions we're going to deal with today are: why should we be doing it? Should we be doing it? Is it safe? Is it safe enough? How to improve that, both in terms of safety, but also efficacy, and also just some practical considerations as we begin to unpick the longer term benefits of this. So the starting point here has to be, on paper, does it make sense to treat patients with food allergy? And the reason that that is an issue is because the likelihood of something really bad happening to you with food allergy is actually remarkably small. For those of you who've joined previous conferences, you may recognize this slide. It was work done by Bob Boyle, one of our colleagues at Imperial, where the team looked at the likelihood of something bad happening to you if you are a member of the public with food allergy, and in this particular case, a young person, so under 19 years of age. And bad things could be due to your food allergy or could just be due to accidents. And as you can see, around 1 in 250 people would go to the emergency department because they've been involved in a motor accident. And that's then extends over to being struck by lightning and dying, about 1 in 10 million. And the likelihood of dying from your food allergy is actually lower than the likelihood of dying in a car accident or crossing the road or making your way to your annual appointment in hospital for a review of your food allergies, and so on. And that's not to minimize the potential impact of food allergy. What it does is highlight the fact that actually we seem to be, on the whole, protected quite a lot from really severe outcomes. And fortunately, in countries the size of the UK, we only have about 1 fatality every month or so due to foods, which is very minimal compared to other conditions, including, for instance, asthma, let alone before we start thinking about pediatric oncology. And I suspect that's probably one of the reasons why we struggle a little bit to get funding onto the agenda, because it just doesn't kill people. There is a morbidity. That morbidity is a little bit associated with having anaphylaxis, having to go to hospital, being observed overnight, and so on. But in terms of prolonged admissions, it just doesn't really happen. And it's much harder to get data on the impact on quality of life, which we'll talk about a little bit, because that's actually where the massive impact is. It's not on the figures of admissions and so on. It is actually on the ability of people to do a normal activity, which is have confidence that they're not going to have a reaction to what they're eating. And of course, we all eat every day. And because of that, accidental reactions are quite common. So 1 in 8 children with peanut allergy will, according to some reports, have an accidental exposure every single year, despite the fact that they're following appropriate dietary advice, because it's just a difficult food to avoid. It's becoming easier as there's greater recognition, but it's not necessarily something that's simple, because people get fed up with may contain labels, or if they're eating it out, and there are issues, significant issues of cross-contamination. Milk's even worse. So over half of infants with milk allergy will have a reaction over a 3-year period. So avoidance on its own doesn't work. We need more than that. And as I alluded to, there is a significant impact on quality of life of a diagnosis of food allergy. There's some historic data that shows that if you're a parent of a child with food allergy, the negative impact is greater than if your kid had insulin-dependent diabetes and required injections every day. Now, there are some issues with that data. It's not the most robust data, but certainly the adverse impact is in that ballpark. Some more recent work, which I have to say has been sponsored by Immunotherapeutics as part of their work to get their product licensed in both America and in Europe in particular, has further looked at that. And as you can see on this slide, there's a huge amount of impact on daily activities and a huge amount of impact on socialization. And sometimes if you just take egg allergy, most children with egg allergy are tolerant to egg in cakes and biscuits. It's something that we should be assessing in hospital at challenge. If we don't, essentially we're saying kids can't eat cake. And when do kids eat cake? At birthdays. And actually a lot of people would then go, it's easier for my kid not to go to a birthday party than to go to a birthday party, have to explain why he can't have the cake, why he's different from every single other kid at that party, and so on. And so there really is a massive impact on socialization, in which we, living in the COVID era, we can begin to understand how critical socialization is to normal child development, let alone adult development and happy mental health and well-being. Some recent work has begun to look at safety and efficacy. And some of you may be aware of this publication from The Lancet from a Canadian team published in 2019, which reported that if you undergo immunotherapy to peanut, you are more likely to have anaphylaxis. And there was a little bit of a, hoo-ha when this came out, because people were like, no, immunotherapy is wonderful. But the bottom line is that if you are allergic to peanut and you're taking a dose of peanut every single day, then your potential exposure is so much greater, because you're being exposed on a daily basis to the thing that you're allergic to. So it's hardly surprising you're going to have more allergic reactions. And actually, if anything, this systematic review, underestimated things. So if you just look at the first study, the STOP2 study, which was a UK study looking at immunotherapy, in this study, around there are 6 episodes of wheezing, and something like 20% of people at some stage during the study had wheeze associated with their dose of peanut. It was not termed anaphylaxis, but because only one person administered the EpiPen in response to that episode, the number of anaphylaxis due to OIT was just in that one person out of 49, and not in the 20 or so % who had wheezing at some stage. And so it's, if anything, this is a bit of an underestimate of the anaphylaxis risk. And you can see that in terms of looking at broader adverse events, again, quite clearly it favors no immunotherapy. That then led a little bit to a report from the Institute of Clinical and Economic Review, which is a sort of quite a heavyweight think tank in terms of health economics in the USA, where they said avoidance is better. And that then led to a whole raft of responses from people who went, no, you've got it wrong, and so on. But nonetheless, we now have an FDA-approved treatment for peanut allergy, which is essentially peanut in a capsule, peanut powder. And it seems likely that it'll be approved in Europe within the next 4 to 6 months on the basis of an opinion that's been very favorable from the European Medicines Agency. But let's bring some perspective here. So the first thing is that immunotherapy is not new. We've been doing it for over 100 years. The first report of immunotherapy was to egg, reported in 1908 in The Lancet. And as I mentioned, of course, you're going to have more adverse events if you're taking a daily dose of what you're allergic to, because food allergy occurrence of reactions is unpredictable and severity is unpredictable. We don't have an international consensus at the moment on AE reporting, so we're all basically doing our own thing and making up as we go along. The Chu meta-analysis I showed you didn't do a full analysis on improvements in quality of life. So it was based on efficacy, which we know works, and I'll show you some more data on that. And it was based on safety, but it didn't actually look at what patients think. And that's really crucial, because we've got a paradox here. On the one hand, we've got this increased rate of adverse reactions, increased rate of anaphylaxis. But on the second hand, we've got a very low dropout of participants who are having those adverse events. And people are keen to sign up for these things, despite the fact when we consent them, we say 1 in 5 are going to fail, and 1 in 10 are going to have anaphylaxis, and 50% are going to have significant adverse events, yet they still sign on the dotted line. So quite clearly, it's not so straightforward. And then, of course, the other thing is that a lot of these data are only from when we're establishing patients on immunotherapy. What's more important is that once you've had the treatment, what are things like? Are you still having adverse events? What's your quality of life like then? Because that matters far more to our patients. You wouldn't think for 1 minute, we better not do chemotherapy in someone with cancer because of the side effects. The reason we do chemotherapy is because if the treatment works, you are then alive at the end of it. And while peanut allergy or food allergy is not the same as chemotherapy and the risks of death and morbidity from cancer, it's a similar concept in terms of it's the post-treatment scenario that actually matters. So as I said, we've got this paradox, yet there's clearly demand for OIT despite all these risks. And so we really need to dig a bit deeper. And again, those of you who've joined us for this respiratory allergy forum in previous conferences may recall this model, which I've spoken about before. And it's a model that's derived from the theory underpinning cognitive behavioral therapy, the concept that there are a number of different drivers of anxiety, one of which is your perception of severity. So if you think you're going to die every single time you are exposed to a peanut, you're going to be very anxious about your peanut allergy. The truth is that 50% of peanut allergic people can eat around half a peanut with very little happening to them because there's a level at which you need to exceed in order to have significant symptoms. But people don't know that because their first reactions happen in scary situations. They might not even know they're allergic to peanut at that stage. They don't know what to do. It's rush, 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 blue lights, ambulance, hospital, noise, beeping. Doctors in emergency might not have full information, might not have time to impart full information about allergy. And so that unsettles people and it drives anxiety. Then there's a perception of likelihood that, you can tell a patient, and I say this as a parent of a child who's had anaphylaxis, you can tell someone the likelihood of bad, severe anaphylaxis proper risk to life is, 1 in 250,000. And as a scientist, we will hear that's pretty low. But as an affected individual, as a parent, we will hear, yes, that's my child you're talking about. My child is at 1 in 250,000. So perception of likelihood is also abnormal. And then the perception of being able to deal with the reaction, being able to treat it, knowing that the treatment is going to work, that is low. And so if we are going to do the best for our patients, if we can address those drivers of anxiety, then we can improve their lot. And immunotherapy may or may not be part of that. So after immunotherapy, what happens is that we reduce the perception of severity and the perception of how likely a bad reaction is happening, because these kids have been taking, or these adults have been taking their doses every single day. And they've had controlled reactions with us in hospital to prove they have an allergy, to show whether the treatment has worked. And so again, we shift their perception of likelihood of severe reactions and their perception of severity. Plus, because they've had reactions, their perceived ability to cope is increased, particularly if they use their adrenaline pen. And this is just one patient of ours. It's given me permission to show you this video, if it works. I'm not sure it is going to work, unfortunately. But essentially, he's having anaphylaxis. As you can see, he's not an extremist. He's just having a little bit of wheeze. And he was able to use his adrenaline pen and didn't even flinch when he used it, because actually adrenaline pens don't hurt that much. And maybe we should all be getting our patients to self-inject with adrenaline as a practice so that they overcome their fears of using their pens later on. That's work that we looked at a little bit. We looked at patients in hospital who had anaphylaxis and then self-injected with our support versus patients who didn't have anaphylaxis. And we looked at their quality of life change just due to the impact of that food challenge. And you can see here that in pretty much in all cases, there was a shift towards a reduced impact of anaphylaxis, certainly in the overall cohort. And there was a trend towards an increased improvement in people who had anaphylaxis and used their pen. And that trend was significant in parents and also significant in self-report. It wasn't significantly different from those who only had mild to moderate reactions. But that is just because we were slightly underpowered because we could only use the sample size that we had. And furthermore, we've subsequently shown that in all individuals, whether or not they have anaphylaxis at their initial challenge, the improvement after 1 year of immunotherapy, 1/3 of that, 36% of that, is actually all due to the challenge at the start. And only 2/3 of the improvement with treatment of their food allergy is due to the treatment itself. So coming back to immunotherapy, what are we trying to achieve here? Are we trying to reduce the risk associated with possible exposure to traces? I don't personally believe in traces. People react to actual amounts. They don't react to tiny minimal amounts which you can't measure and can't see. That's what a trace is. Is it we're actually trying to desensitize them so that they can have as much peanut or as much milk as they want? Are we trying to cure them actually? Because I'm not sure that's achievable, and that's what the longer term data currently shows. You end up always being allergic. It's just you need to eat 100 or 200 peanuts to have any sort of reaction, whereas before the same reaction would happen with 1/10 of a peanut or 1/70 of a peanut. Or actually, is our main outcome just trying to improve quality of life in our patients? It doesn't matter if there's not a significant increase in tolerance level, but if we have a significant increase in their confidence to eat out and to manage a reaction, maybe that's the most important thing. We know immunotherapy works, at least for desensitization, and there are lots of systematic reviews now. This is just one of the first and one of the better ones, although it's now 6 years out of date, which clearly showed that for peanut, for milk, and for hen's egg, oral immunotherapy works. But after initial desensitization, things get tricky. First of all, 10 to 20% of people fail to respond to the escalation due to significant AEs and have to drop out. 10 to 20% don't get to the stated outcome. They only get what we call partial tolerance, so they might tolerate 2 or 3 peanuts rather than 10 or 20 peanuts. Actually, that's probably still beneficial for many. And the long-term tolerance is very poor. Probably after 1 year of stopping, you're probably down to about 25% still maintaining that level of tolerance. That is probably longer if you do treatment for 3 years or for 5 years, but there's not much data in that area at the moment. I've already mentioned we don't have an international consensus on how to report safety, and you might be cynical and say that there's a tendency to report safety in a more favorable manner. So for instance, studies which report wheezing as opposed to reporting occurrence of anaphylaxis, or studies that report gut symptoms of which the majority were mild, as opposed to saying gut symptoms of where 57% were mild and actually 30% were severe. 57% is still a majority. There's a tendency to sort of skew the, spin the story so that the data gets published in more impact journals, I think. And that's why we need an international consensus on exactly how we should be reporting. And we know that low-grade symptoms are common. And so, for instance, in our peanut studies, our teenagers frequently get itchy mouths and itchy throats when they have their daily doses. It only lasts for 5 minutes, but actually that bothers them, and their dose event becomes a scenario they want to avoid. And there's lots of teenage behaviors that they then take to try and avoid that and put off them having their dose. And we need to think about how we deal with these low-grade chronic adverse events. So what barriers are there at the moment? So we know ORT involves increased risk, and potentially you can have anaphylaxis, and we need to have safety netting in place to do that, because at some stage we are going to kill someone due to OIT, because the reactions are largely unpredictable and food allergic reactions are unpredictable. Gut symptoms are common, and we need better ways of dealing with gut symptoms for those who have them. And at the moment, we tend to focus on patients who aren't in the more severe end of the spectrum. But what about those patients with more persistent allergy, those who've required 3 or 4 doses of adrenaline in the past to fix an anaphylaxis reaction? Those patients who have asthma that's actually not difficult to control, but not easy to control. What about them? And we need to think about longer term commitment and supervision, particularly when we do this in teenagers. And so we need to think about how to overcome those barriers and not just be like sheep and following the leader and falling off the cliff. We need to work out how we deal with those people with poor prognostic factors and what those poor prognostic factors actually are, how we can improve protocols, whether that's changing the dosing or using adjuvant therapies such as anti-IgE therapy, or there are a couple of strategies using probiotic or symbiotics, might that help? How we can modify the allergen to make it less likely to cause an allergic reaction, but yet still stimulate the immune system to develop a tolerizing response, and to look at longer term outcomes. So for example, in people who are tricky to initially updose, should we, for instance, consider sublingual immunotherapy to help them get to a certain point where we can then switch them over to oral immunotherapy? Or for people who've achieved a degree of desensitization, but hate the taste of what they're having to eat every single day, can we then use epicutaneous immunotherapy, exposure through the skin, for longer term maintenance? Would that do the same thing? There isn't really much data yet to tell us what to do after initial treatment. And this small study from Italy, one of the only ones out there, looked at 2 regimes after successful desensitization to cow's milk, and they found that having the dose just twice weekly, as opposed to daily, was as good, although there were still unpredictable breakthrough reactions, including anaphylaxis. And we need to think about, okay, we can do it for patients, but what about the broader population? We know there's significant disparities in access to allergy services due to ethnic differences, socioeconomic differences, differences around the world. Are we even going to be doing this in countries outside Europe and America and Australia at the moment? And we need to think about whether it's a good use of resources, because if it doesn't kill people, it's hard to make the health economics case that this is worthwhile funding, as opposed to all the other things that need funding for child health. And then finally, we need to have a shared decision-making process where actually we involve our patients and their families, and we can voice the concerns, and we're totally upfront with the risks and the commitment that's needed, and how to do this safely in order to ensure we do it safely and it works for our patients. I'm going to stop there, and I'll be delighted to take questions.
Thank you so much, Paul, for another absolutely fantastic talk. I have just a couple of questions which have been bugging me for a long time, as you know. There's the issue of prediction of patients who may run into troubles during immunotherapy, the 10 to 20% that you described, who really, really struggle during the initiation dose. And probably that is kind of, it's very, very similar to what has been described in other forms of immunotherapy, for example, subcutaneous for Hymenoptera venom. Now, whilst I fully appreciate that at the moment we do not have any biomarker, what would be your practical advice as to how to approach this? How to identify, based on your experience, those children with whom we may struggle?
The kids who seem to struggle are the ones who are more sensitized. It's interesting. It's not actually related to the people who react to tiny amounts, milligram amounts. I've managed to successfully desensitize the most allergic kids in terms of the amount needed to trigger them. It's the people who are more highly sensitized, bigger skin prick wheals, or particularly bigger, larger sort of specific IG to peanuts or to milk. They're the tricky ones. but we can't spot them because for every kid who is tricky with a high IgE, I've got 3 with high I or 4 with high IgEs who are completely easy and a doddle. It just so happens that the tricky ones are in the top end, but there are lots of easy ones in that top end group as well. So we do need some sort of biomarker, but actually you can probably get a sense on whether someone's going to be tricky fairly early on in terms of when you're doing dose escalation and whether they respond or not. And what we need are strategies to manage their symptoms, and we've worked some out. Some are reported, some aren't yet reported, in terms of helping people with their symptoms. And I guess at some stage there's a question of, if it's really hard and the going gets tough, can we justify a case of 3 or 4 months of anti-IgE monoclonal therapy to get them over the bump? And maybe we can, if those are the people who've had previous truly life-threatening reactions.
Another question, I mean, seeing your extraordinary studies on adrenaline auto-injectors, and the actual, it's almost transformational, isn't it, to see kids who self-administer AAI, after which the cloud of anxiety kind of vanishes and they're almost transformed. Your suggestion, which I find really interesting, should we actually sort of stop giving them toys and trainer pens, and for those whom we deem to be at high risk, get them to self-administer the real dose? Would it be £30 well spent, given the impact it has on quality of life of patients and families?
Yeah, I think so. I mean, I've said for a couple of years now that the manufacturers should make real devices that do a saline injection, and because that, and then once every few years, particularly in teenagers, for them to practice with a real injection in the clinic, if they want to, would be an immense positive impact on their management, and also on their parents' concern that they wouldn't use their pen if they needed to. We don't have those saline injections. Injecting with a needle syringe, which some clinicians have attempted, just isn't the same. And so sometimes what we started to do is, when we've got the lower doses, so the 150 microgram doses that you'd use in young children under 6, sorry, under sort of, yeah, I guess, under 6 to 8 years, we would use those in the teenagers, because then it's a lower dose and they have that experience. We're not doing that clinically yet, but I think that is probably one of the most effective things we could do in our 10 minutes with them in clinic, rather than waffle on with them about how they mustn't eat their peanuts anymore. I think that would be a significant improvement, and we need to think about getting data perhaps to prove that that strategy is effective. The problem we've got is, the bottom line is, often the data is, the outcome that would be most desired is, if you had an accidental reaction in the community that was anaphylaxis, would you then use your pen? And because the frequencies are so low, we would need thousands of people in those studies in order to be powered for that outcome. And then it will therefore rely on surrogate outcomes instead, like quality of life, which aren't really accepted by the people who control the money bags.
Thank you. Thanks very much, Paul, for sharing your knowledge and your expertise. I know that you have to go back to look after the patients who are being challenged and who are on OIT. Thanks very much for joining. I'm sure we'll see you at this meeting, hopefully face-to-face next year. And we really greatly appreciate everything that you have done. Thanks, Paul.
Thanks, everyone, and enjoy the rest of the meeting.
Okay, and after this talk on oral food immunotherapy and food allergy, we're going back into respiratory area. I will be next speaker. I'm Professor of Pediatric Allergy at Imperial College, and my general interests have been, through over the last 25 to 30 years, the trajectories of respiratory health in during life course. And the area I would like to cover today is that of the early life origins of COPD. COPD, the disease that has been quintessentially considered to be a self-inflicted injury in which adults, due to taking up active smoking, lose lung function progressively through life course, thereby ending up having COPD. These are my disclosures. I do not believe that any of them is relevant for this talk, but please do make your own informed decision. The areas that I would like to cover today really starts from addressing the role of early life events, which I believe are absolutely critically important for the development of COPD, but not just COPD, also the lifelong lung health. And it really is almost like an introduction to what Marielle is going to be talking about with long-term consequences of BPD in the next talk. I'm also going to stress that there is really much more to a low FEV1 at physiological peak in third decade of life than just asthma and later life COPD. Ask the question whether it is possible to identify very early those children who are at risk of subsequent troubles to come. I'm going to just touch upon a couple of really what I believe are important markers: multiple early allergic sensitization, and very importantly, severe wheeze exacerbations, linking it to the talk that SEJAL has given just half an hour ago. I'm going to touch upon other biomarkers and ask a question whether it is possible to intervene during or after these crucial preschool years. So let's start by the natural history of COPD. And it is quite extraordinary that over the period of best part of 40 years, this publication by Fletcher and Peto was really a description of the natural history of COPD, with the idea that crucial changes in lung function that defy this disease are results of changes taking place slowly over the period of several decades, starting from optimal health in your mid-20s. Now, when you look at this graph, I mean, it is really extraordinary view of life by an adult physician, where life really starts when you're about age 25. It assumes that by age 25, we all fully formed with our wonderful lung function of 100%. We just appear miraculously out of nowhere. Now, it is fair to say that whilst this graph has been extensively used in the original Fletcher and Peto paper, which is well worth reading, there is another graph which says very clearly, well, perhaps this is gross oversimplification, and there indeed may be individuals who get to this critical point at age 25 with diminished lung function. And the whole view of COPD.
Excuse me, I'm so sorry to interrupt, but your slides are frozen. Can you try unsharing your screen and sharing it again?
Yeah. Okay. So at which point has it
a few minutes ago, exactly. The title page. Yes, and if you go to display settings.
It says I'm sharing.
Yes, we can see your screen now, but could you go on display settings, please? On top. On top of your screen. On the left corner.
Yeah.
Yes, click on display settings.
I don't have displays here. I have annotate. I have.
Look at the other screen.
So duplicate slideshow or swap presenter view in slideshow?
Swap presenter view. Yes, thank you so much. Sorry to interrupt.
Can you see it now properly?
Yes.
Which slide? The Framingham one, yeah?
Yes.
Okay, so as you can see, this was really critically important study published a few years ago. Analysis of participants in 3 cohorts: the Framingham offspring, the Copenhagen City Heart Study, and Loveless Smokers Control, according to lung function. What is important to say here is that the investigators in this study assign individuals to their lung function trajectories based on their own assessment of where they felt the lung function was. It was really, really interesting. They described 4 unique lung function trajectories. Interestingly, 2 of those led to the development of COPD. One of those, the typical one, fast decliners, the one described so well in Fletcher and Pito. And then the other trajectory, the trajectory with absolutely normal decline, but when individuals starting with low lung function at physiological peak in 3rd decade of life. Interestingly, both of these trajectories contributed equally to the development of COPD, but the differences in rates of decline remained unexplained. And this is not the first time that we have noticed that suboptimal lung growth in childhood may be precursor of adult COPD. In one of the sort of really critically important studies, the Melbourne Asthma Study, it was absolutely clear that amongst individuals who have been assessed from age 10 years up to age 50 years, those with COPD and diminished lung function at 6 years of life had significantly impaired lung function as early as age 10. And the odds ratio, the relative risk of COPD in the 6th decade of life, was increased 30-fold amongst those who had the diagnosis of severe asthma. And I'm going to stress the diagnosis of severe asthma, not necessarily just severe asthma. Fernando Martinez then went on to do an unsupervised data-driven analysis, applying latent class analysis to lung function data from a large number of individuals, almost 600 individuals from 2 respiratory study, describing 2 fundamentally different trajectories. One here, normal lung function trajectory, and another comprising approximately 9% of population with diminished lung function. Asking important question, what would be the functional and health consequences of this diminished lung function? And associates of diminished lung function with maternal asthma, interesting early life RSV, respiratory tract infection, physician-diagnosed active asthma, and lower lung function in infancy and at age 6 years. Now, in the UK, we had an opportunity to model lung function from preschool age up to physiological peak in 2 birth cohorts in our STELLAR cohort in Manchester and Alspach. About 2,000 individuals across 2 different populations followed from school age into adolescence and early adulthood. And strikingly, the pattern of lung function was remarkably consistent across 2 cohorts, with up to somewhat less than half of population, 4% of population having really persistently very, very good lung function, and equal size between 3 and 7% of population having persistently low lung function. Why do individuals have persistently low lung function? Is it because of genetics? Well, we looked into this because Spirometer Consortium has done some fantastic work looking at genetic associates of lung function in adulthood. So how much can genetic associates of lung function in adulthood predict trajectories of lung function during childhood? Well, very, very little. Actually, all 136 single nucleotide polymorphism that were associated with adult lung function in any of the large GWASs carried to date explained as little as 6% of the variance in lung function trajectories during childhood. And environmental exposures were indeed important, and it would not come as a surprise to you that environmental tobacco smoke exposure and maternal smoking was associated with lung function. But interestingly, it was the absence of environmental tobacco smoke exposure that was associated with health, with very good lung function. And I think we need to start thinking more in terms of health rather than disease. In the sister paper, parallel to this one, the same issue of Lancet Respiratory Medicine, Shaimali Demarge and group from Tasmania, who had fantastic lung function data in Tasmanian study following individuals from school age up to age 53 years, applied very similar unbiased methodology to describe almost identical lung function trajectories. Two further trajectories that you see that we haven't described are this one here, which is early low with accelerated decline, really potentially important trajectory. And this one here, which hasn't been described at all before, which is below average in a childhood with actually catch-up. So this one, for the first time, suggested that you can catch up. And I'm going to come back to this a little bit later. What they had an opportunity to do was then go to 6 decades of life and look very carefully as to what are the consequences of these different lung function trajectories to really suggest that the majority of adult diagnosed COPD begins with poor lung function trajectory pathway in childhood. Actually, staggeringly, there were 2 trajectories persistently low and early below average with accelerated decline, where a lot of individuals actually went on to develop further COPD. And interestingly, childhood characteristics of subsequent risk of COPD included childhood diagnosis of asthma, bronchitis, allergic rhinitis, pneumonia, heavy exposure to environmental tobacco smoke, and for persistently low lung function, small group of individuals, but still contributing to adult health, ever personal diagnosis of asthma, eczema and food allergy, interestingly, and parental asthma. The real message from this is it is really important to pay attention to early life events. And then the plot thickened even further, because it is not COPD only that we need to think about in this context. In a great analysis in Tucson study, Fernando Martinez has shown that FEV1 at physiological peak in early adulthood is strong predictor of mortality, early mortality of all causes. And in another study, and I would urge everybody to look at this study, it's fantastic analysis by Alvaro Agusti from 3 large cohorts looking into respiratory, cardiovascular, metabolic disorders and their comorbidities across 3 large cohorts. He has described very clearly that diminished lung function, FEV1 less than 80% at physiological peak, is very strongly associated with subsequent higher prevalence of not only respiratory, but also cardiovascular and metabolic abnormalities in early adulthood, with higher and earlier incidence of comorbidities. So you have up to a decade earlier onset of comorbidities. And interestingly, all of this was independent, but additive to cumulative smoking exposure. So indeed, not only that subsequent adult COPD is strongly associated with early life events, but lung function during childhood to physiological peak unmasks earlier onset of very important comorbidities, really raising the question as to whether lung function is a canary in a mine, warning us of troubles to come. So how early does airway obstruction start? Well, airway obstruction indeed is very early phenomenon. This is data from COPSAT by Hans Bisgaard, where they measured lung function at the age of 6 weeks in more than 400 high-risk babies, demonstrating very clearly that there is a subgroup of individuals with airway obstruction with as early as age 6 weeks. Then they follow these kids subsequently to age 7 years, and indeed, airway obstruction in first couple of months of life was strongly associated with subsequent diagnosis of asthma. And the airway obstruction at age 7 years, well, approximately 40% of it could be explained by antenatal effects, and about 60% with postnatal events. So really, really fascinating, important and interesting data. Does it mean that one of the consequences of this thinking would be, well, if you're born with diminished lung function, is there anything we can do? Are you doomed? We had an opportunity to look at this in PIAF, in Australian birth cohort study, which was set up by Peter Lesweff. And Peter has measured lung function throughout first year of life at age 1 month, 6 months, and 12 months in a large number of individuals. And Steve Turner went over to Perth to do his electives and spend time looking at this data and analyzing these data. And we applied data-driven techniques to describe 2 trajectories of lung function during infancy, below average and above average. What was really interesting is that the majority of infants in below average lung function trajectory during infancy did not actually progress to low FEV1 trajectory. So clearly there is a potential for catch-up. The factors, the predictors that were strongly associated with persistently low FEV1 thereafter were these 2 features that I touched upon earlier: multiple early allergic sensitization and recurrent wheezing with severe exacerbations, particularly during first 3 years of life, linking this to what SEJAL was talking about. So what lung function trajectories give is sort of, I think, slightly skewed idea that lung function tracks. Well, lung function tracks at population level, but within each of these trajectories, there's a lot of within individual variability. So these 2 features associated with subsequent troubles to come, what is their impact on trajectory of lung function? Well, a few years ago, we looked at the development of lung function, now looking at SRO, specific airways resistance, as much more sensitive lung function parameter during childhood, starting from age 3 years to mid-school age, showing very clearly that the highest risk of progressive loss of lung function during childhood from age 3 to age 11 years was amongst children who had persistent wheezing, but those with persistent wheezing and severe exacerbation were the ones in whom lung function loss was most pronounced, and those with multiple early sensitization. So exacerbations of wheezing are clearly important. So we paid attention to exacerbations, asking, well, are there individuals then in the population who frequently exacerbate? So we modeled severe wheeze exacerbation throughout childhood, from infancy to school age at age 8 years. This data was transcribed for healthcare records. So we're really talking about acute severe exacerbation resulting either at hospital or A&E presentation or prescription of oral corticosteroids. And it was very clear that amongst children with a history of wheezing, amongst 2/3 of them do not have severe exacerbation. Amongst a third who do exacerbate, there were two fundamentally different patterns of exacerbations. One, here in magenta, children who start with exacerbations in early life and have frequent exacerbation, early frequent exacerbation. You can see some of these kids have 8 to 10 courses of oral corticosteroids per year during early life, and children with infrequent exacerbations, so exacerbation, 1, 2 exacerbation here and there during childhood. Now we had an opportunity to follow these children up to their adolescence, and it was quite striking. Looking at lung function here, Tifno index, something that everybody is familiar with, it is absolutely clear that children with frequent exacerbation in frequent exacerbator cluster had progressively diminished lung function from age 8 to age 16 years. And you can see these marked differences between children with frequent exacerbations and those with wheeze without exacerbations, those who exacerbate occasionally, and children without wheeze. And really, there is practically no impact on lung function in these three groups. So if we could reduce frequent severe exacerbations in early life, perhaps the impact would be really fundamental. So all of this data tells you very clearly that you can lose lung function during certain developmental periods in the life. Can you gain lung function? Is there a potential to catch up? This is analysis that Osama Mahmoud did in a context of ALSPAC as part of Alex's study, looking into within individual associates of change in lung function, describing a subgroup of individuals with a catch-up with increased FEV1 and FVC during important growth phase in puberty, describing an association of later pubertal age and rapid pubertal growth with increased FEV1 and FVC, particularly amongst boys who were thinner. Now, I will not for a second suggest that we should perhaps try to delay puberty. No, never. But maybe we should target modifiable childhood factors such as obesity and overweight, and that may contribute to pubertal growth patterns. So how do you reconcile these findings? Well, I think all of the evidence today suggests there is little doubt that for the majority, lung function when you first go to school tracks to late middle age. Tracking may actually start very early in infancy, and as the data from Tucson and Kopsak, there may be a first 2 decades catch-up, particularly in that small group that was described in ALSPAC, but I would say this needs confirming in another cohort. What is though clear is that early low FEV1 and FEV1-FVC ratio are signs of early, not respiratory, but all-cause mortality. All-cause mortality. We can really impact upon health. The question is, what can we do now in terms of public health? What would be the intervention? Should we perhaps assess lung function as early as possible in childhood as a marker of subsequent respiratory, but also cardiovascular and metabolic diseases and their comorbidities? Is it too late when children get to school? All of these questions we do not have answers to. What though is absolutely clear, that it's early life smoke exposure, early life recurrent severe wheeze exacerbation, and multiple early sensitizations, which are the signs of troubles to come. So how do I see that? Well, clearly, it all starts very, very early in utero, if not even before that. And the child has its genetic code, its DNA. At the same time, there are a number of in utero exposures to maternal smoking, air pollution, increasing concern about vaping. all of these act upon fetus, but also interact with genetics, causing dysregulations of placental function, fetal growth restriction, really have impact on lung structure that can lead to preterm, to cesarean section. We'll hear about all of these consequences later on. There's also an important issue that links this to SEJAL's talk earlier, which is there is clearly a reduction in exposure to microbial diversity during this, even in utero important period, which then in turn leads to functional immaturity of key immune and effector regulatory mechanisms during infancy. Now that functional immaturity puts you at risk of acute attacks of wheeze, and you have acute severe attacks. There is no airway inflammation there, SEJAL has shown you that, but that does increase your susceptibility to then develop this interesting feature of multiple early sensitization, which linked with other environmental exposures leads to the development of airway inflammation somewhere between ages of 1 and 3, which is very, very consistent with SEJAL's data. This then leads to progressive loss of lung function into impaired lung function trajectory and troubles to come. But it also means that there is this window of opportunity where we can intervene. The question is how and with which measures. And with that, I need to thank a lot of people who have contributed to this, my friends and colleagues from Stellar Consortium, Angela Simpson, Claire Murray, never forgotten Professor John Henderson, whose contribution has been tremendous, our data science team, and everybody else who contributed to this data. And with that, I would like to thank all of you for your attention, and I'm more than happy to check whether there are any questions in the chat box, and we can then start with following section. Marianne asked really, really important question, which is, what would be your advice to our colleagues, respiratory physician treating adults with diminished lung function who already started with lung function in early childhood? Well, I think we have a real problem in organization of healthcare at the moment with difficulties in ensuring that vertical transition. We also have critically important period of adolescence and young adult health when sometimes these individuals fall between the two services. We need to ensure a much better dialogue between pediatric and adult community. And I would suggest that probably in congresses like ERS, etc., we should do our very best to come together rather than to stay apart. It is also interesting, isn't it, Marielle, when they say, well, you know, let's take an example of severe asthma, that adult severe asthma is supposed to be very different to pediatric severe asthma. Well, actually, I would say there are a lot more similarities between school-age asthma and adult asthma than there are differences. And certainly children whom we see in our pediatric severe asthma clinics today are the children whom our adult colleagues are going to be seeing in 10 to 15 years. Individuals whom they are seeing today are the ones we've seen 10 to 15 years ago. But the pattern in pediatric severe asthma clinics has also changed. And without understanding it, without that knowledge, I don't think we're giving real justice to all of our patients, but also to preventive strategies. That would be integration, vertical integration being tremendously important. Okay, now with this, I'm going to go straight into our next talk. It's Marielle Pijnenberg. Marielle is Secretary of Pediatric Assembly of ERS and has contributed tremendously to really ensuring this integration with adult services, and I'm tremendously grateful to her for that. She's professor at Erasmus Medical Center, and she's also head of Department of Pediatric Respiratory Medicine, has made tremendous contribution not only in asthma, but also in CF and in BPD, and I'm really looking forward to the talk on the consequences of BPD and what I mean, this would be really great to have adult physician on this as well. Over to you, Marielle. Thanks very much for being with us today.
Thank you very much for this very kind introduction. Well, around 8% of all the children in the world are born preterm. And in the next 20 minutes, I will talk about the consequences of a severe complication of this preterm birth, and especially extreme preterm birth, which is bronchopulmonary dysplasia. I have no disclosures that relate to this presentation, except some research funds for BPD studies. And in the next 20 minutes, I will like to talk you through the long-term consequences of BPD, actually starting from discharge from the neonatal intensive care unit into adulthood. And I will focus, as I'm a pediatric pulmonologist, on respiratory consequences, but also will discuss cardiovascular consequences. And I will only touch very shortly on neurological and social consequences, which are really very important as well. And in the end, I hope to convince you that children with bronchopulmonary dysplasia deserve a multidisciplinary follow-up into adulthood. And I will talk about our own multidisciplinary follow-up program. As you all know, bronchopulmonary dysplasia is one of the most common complications of extreme preterm birth, especially in children below the gestational age of 28 weeks. And to give you an impression, in the US, every year 48,000 children develop BPD, of which 12,000 go home on home oxygen and even 200 leave the hospital on home ventilation. You all know that the incidence increases with decreasing gestational age, and actually all children who are born after 23, 24 weeks of gestation will develop BPD. And this incidence decreases to 22% at a gestational age of 28 weeks. Remarkably, this incidence has been stable during the last 10 years. We have better treatments in the very preterm immature babies, but on the other hand, we are able to treat very, very immature babies, babies born at 23, 24 weeks. And of course, they have a much higher incidence of BPD. So this makes that the incidence has been stable during the last 10 years. This is a slide on the pathophysiology of BPD, and I'll talk you through. I'm not sure if I have a pointer. I don't think I have. But in the upper left corner in the upper panel, you see all the risk factors actually for bronchopulmonary dysplasia, and it's very clear that bronchopulmonary dysplasia is a multifactorial disease. There are prenatal risk factors, especially infections and fetal inflammatory diseases in responses. Growth restriction is an important risk factor for BPD. Genetic backgrounds may predispose children to BPD, and of course, prematurity is the main risk factor. And postnatal risk factors include infections again, but also oxygen toxicity, mechanical ventilation, malnutrition, persistent ductus arteriosus, fluid overload, and there's a difference between boys and girls. And all these risk factors work on the developing lung, the developing alveoli, airways, but also on the developing vessels. And in the middle of my slide, you see 4 important mechanisms leading to bronchopulmonary dysplasia, which is a deficient alveolarization and vascularization of the lung. Altered growth factors are involved, for example, VEGF or NO synthase. Free radical damage and oxidative stress play an important role. And there's also remodeling of the extracellular matrix. And these 4 mechanisms lead to impaired lung growth and function, to pulmonary hypertension, to impaired immune function of the lungs, and also to impaired repair capacity and preterm lung aging. This pathophysiology leads to the pathological findings we can find in children in the lungs of children who died from BPD. And you can see on the right a pathology slide with less and bigger and simpler alveoli than in normal term-born babies. There's hyperplasia of the smooth muscle cells of the airways, and the pulmonary arteries show hypertrophy as well. There's fibroproliferation in the lungs, and these pathological findings lead to collapse of the airways and to a decreased diffusion surface. This less and simpler alveoli lead to a less diffusion surface and may explain the oxygen need many babies with BPD have. In the past, we tended to believe that alveolar growth stops at the age of 2 to 3 years. However, recent studies with hyperpolarized helium MRI show actually that this alveolar growth continues into adolescence. And a very nice study in the Blue Journal showed that at school age, actually, there was no difference in the so-called apparent diffusion capacity and alveolar dimensions that are the parameters that you can extrapolate from this hyperpolarized helium MRIs. They didn't show any difference between children born preterm with BPD or born preterm without BPD, suggesting that at least there's alveolar catch-up growth in these children. Then, of course, there are also important external factors that influence lung growth: diet, exposure to tobacco smoke, exposure to air pollution, and as SEJAL explained in the first talk on asthma, also the microbiome probably plays a role in BPD. And these factors actually pave the way for prevention of secondary damage, and I think that's really very important. Bronchoobstruction is frequently seen in children with BPD. Some of those children have reversible obstruction, but some don't. And this bronchoobstruction is caused by structural changes in the airways, like the remodeling I showed you in the pathophysiology slide, but also by an active inflammatory process. The nature of this active inflammation actually is not clear, but that there's some ongoing process is actually quite probable, and I will show you that in the next slides. This obstruction may be even worse if children are exposed to tobacco smoke, air pollution again, to viral infections, and if they have a genetic predisposition. And again, here I think prevention may play an important role. So what are the consequences of BPD if you look at symptoms? Well, we all know the very young children with BPD, especially during the first year of life, who have frequent respiratory symptoms like wheezing, dyspnea, and cough. 2/3 of all the children born before the gestational age of 29 weeks have such symptoms, and 1/3 of them have severe symptoms. And clearly, bronchopulmonary dysplasia is an important risk factor here. If you look at school children from the age between 4 and 8 years, and these are data from Australia, you can see that many of these children, even at school age, have wheeze, cough, and have a doctor diagnosis of asthma in 24% of the cases, and 36% of children have symptoms on exercise during the last 3 months. If you look at adults, up to 71% of them have cough, dyspnea, or wheezing when they had BPD as a child. And there's twice as much wheezing in the adult population, and adults with BPD use more than 3 times more asthma medication compared to healthy adults. And they also report a lower quality of life. If you look at admissions, we certainly know that many children with BPD are readmitted during the first 2 years of life, mostly for viral infections like RSV, but also for other reasons. This higher incidence of admissions is also seen in children who reached school age. children born before a gestational age of 28 weeks have a twice as high admission rate if you compare these children to children born term. We don't have any data on adults, but I expect that some of the COPD admissions in adults are actually admissions because of BPD. So this was about symptoms. What about lung function? Adnan talked a lot about lung function and lung function trajectories. So it's really very important that so it's really very clear that lung function as a child tracks into adulthood. This is a meta-analysis of all the studies looking at lung function in children with BPD. And as you can see on the left panel, there is a decreased FEV1 with a mean difference in preterm born children of 7% if they don't have BPD. This is even worse in the children who have BPD, and these children have a mean difference of even 16% FEV1, which is really very clinically significant. However, there's good news. As we seem to do better during the last decades. Here on the x-axis you see year of birth, and on the y-axis mean FEV1. In white are healthy controls, and in black children with BPD. And as you can see, the mean FEV1 increases during the last decades, suggesting that we are doing better. However, there's also bad news. Here you see two studies showing longitudinal data of lung function in children with BPD. The first study included 267 children born before 32 weeks of gestational age. Some of them had BPD, some didn't, and they were compared with term-born controls. Children were followed between the age of 4 and 12 years. And as you can see in the figure, in the dotted line are the children without BPD. They start with a normal predicted FEV1 Z-score of 0, as you can see on the y-axis. And you can also see that there's a gradual decline during time. However, the group with the BPD, the blue line, they start with a lower FEV1 Z-score, minus 0.5, and they show a decline of 0.1 Z-score per year. And this decline was worse if bronchial wall thickening was present on CT scans and if children were exposed to tobacco smoke or had a lower gestational age. And in a second study, where children born with extremely low birth weight were compared with controls, and these were children with and without BPD, in general, they had a decline of 6.4% in FEV1 between the age of 8 to 12 years. So in the last decades, we are doing better. Children have, in general, a better lung function. However, lung function declines during childhood and tracks into adulthood. And this actually suggests that BPD is not a process that stopped after birth, but that there is at least some process going on during childhood. And again, prevention here is really very important. Other lung function tests, we often see bronchodilator response in children with BPD, more bronchial hyperreactivity, conflicting data on lung clearance index. Diffusion capacity is lower, 8 to 16% lower. FeNO is normal, which is FeNO is a measure, a surrogate marker of eosinophilic airway inflammation. So at least this suggests that the inflammatory process in BPD is not an eosinophilic inflammatory process. In general, there's a slight decrease in maximal oxygen consumption. However, this did not seem to be really clinically relevant. So what about lung structure? If we look at CT scans in children with BPD, the vast majority of them have structural abnormalities, and these are especially hypodense areas, subpleural opacities, bronchial wall thickening, bullae, emphysema, and all children have an abnormal architecture of the lung. Scores on CT scans are associated with clinical parameters like days on oxygen and lung function, but also with weight at 6-month corrected age, which we studied in our own cohort with PPD patients. And this is a CT scan of one of our patients. And you can see in green the normal lung tissue. In blue, you see the hypodense areas. The red color is for the bronchial wall thickening, and the purple color for the opacities, for the pleural opacities. Other consequences, other respiratory consequences of BPD are airway malacia. We see airway malacia more often in preterm children, probably because of the more flaccid airways of preterms and the effects of positive pressure ventilation on these airways. And in rare cases, children may be dependent on positive pressure ventilation or even need a tracheal cannula. Subglottic stenosis is a frequent complication of long-term intubation, as you all know, and some children also present with vocal cord paralysis because of clipping the ductus arteriosus. Obstructive sleep apnea is more frequent in preterm-born children, and this is really important as OSA also increases the risk of failure to thrive, is associated with worse neurocognitive outcomes and pulmonary hypertension. And if you look in school children, there's a 3 to 5 times higher prevalence of OSA in children born preterm compared to the term controls. Also, breathing regulation seems to be disturbed in children with bronchopulmonary dysplasia, even at an adult age. And this might be due to less sensitive chemoreceptors within the carotis, leading to less hypoxic drive. And this breathing regulation is more disturbed if children have been ventilated for a longer time and needed longer oxygen. And this may have consequences if people want to take a plane or if they are staying at high altitude. So this part was on respiratory consequences, but of course the lungs also contain a lot of vessels, and the next few minutes I will talk about cardiovascular consequences. And actually in this slide in the middle you see the main mechanisms leading to bronchopulmonary dysplasia and pulmonary hypertension in preterm-born children. First, there is a dysmorphic vascular development, and this may be due to altered angiogenic signaling. This leads to decreased secondary septation, leading to abnormal alveoli, and these two mechanisms lead to the bronchopulmonary dysplasia. However, this decreased secondary septation leads to bigger, simpler alveoli, leading to decreased gas exchange, to hypoxemia, and hypoxemia again can lead to pathological vascular remodeling. We also see an increased pulmonary vascular tone in children with BPD, and this vascular remodeling and increased pulmonary vascular tone may lead to pulmonary hypertension. So there's a reactive component which may be responsive to pulmonary vasodilatation, but there's also a fixed component due to underdevelopment of the pulmonary vasculature. And this phenomenon is more pronounced in children with a growth restriction. So if you look at the incidence of pulmonary hypertension in the literature, this is actually reported as quite high, 17 to 43% of children with severe BPD. And pulmonary hypertension is clearly associated with high mortality. This was not very clear at school age in several studies. However, if we look in our own cohort of children, and these are data from some time ago, where we looked at 70 children with severe BPD born at around 26 weeks of gestational age, we had an incidence of 12% of pulmonary hypertension at 6-month corrected age. And this pulmonary hypertension was associated with a decreased right ventricle systolic function. Of course, it's really difficult to make a diagnosis of pulmonary hypertension in very young children, as the gold standard is cardiac catheterization, but this may be really difficult in this very vulnerable population. So in general, we use surrogate markers by ultrasound. This is a very interesting study in adults, a small study in 10 control adults and 10 adults born preterm. And on the left corner, you see the mean pulmonary artery pressure, which was derived with cardiac catheterization. And as you can see, this was higher in the group born preterm. And around 50% of the individuals tested in this study had pressures above what we would call pulmonary hypertension. Cardiac index was similar for the two groups, but total pulmonary vascular resistance, the lower left corner, was higher in the preterm born group, and also elastance was higher, suggesting more stiff vessels. So I showed you that BPD has important respiratory and cardiovascular consequences. Also, neurological consequences are very important, psychological consequences. And the impact of having a child with BPD is really very high on the quality of life of parents, especially in the first 2 years. So this together means that I really think that children with BPD deserve a multidisciplinary follow-up. We started this follow-up some 10 years ago in a collaboration with our neonatology, cardiology, ENT department, physical therapy and psychology and social workers. And actually we pick up the children at a corrected age of 2 to 3 months and follow them into adulthood. We have a respiratory physician with a special interest in bronchopulmonary dysplasia who's seeing the adults with BPD as well. And this multidisciplinary follow-up is focused on early detection of problems and prevention of secondary damage. And of course, we also get a lot of research questions from this follow-up. An example of another follow-up program is shown in this slide. So there are actually two parts of the follow-up program: the screening with spirometry, overnight polysomnography, chest CT, echocardiograms, and you have a preventive care part focusing on avoidance of triggers, prevention of aspiration of infections, vaccinations, etc. And both parts try to focus on early detection of preventable factors. This is another example from the US, and in this follow-up program, patients are already identified on the neonatal intensive care unit. When parents are already educated on BPD, there's a weekly or monthly meeting about all the patients with BPD. There's a very accurate discharge planning and an outpatient management program, which focuses on medical factors, social factors, and developmental factors, clearly assessing the needs of patients and parents. And with this very intense follow-up program, the authors were able to reduce the percentage of readmissions to hospital in the first 2 years of life from 29% to only 5%, which is really very impressive. And second, a significant lower percentage of children had low scores on the Bailey compared to national data. So suggesting that a multidisciplinary follow-up program may improve outcomes of children with BPD. So that brings me to my conclusions. Children with BPD have lifelong increased risk of respiratory symptoms, a lower lung function that tracks into adulthood. They all showed structural lung damage and have a lifelong increased risk of pulmonary hypertension and right ventricle dysfunction. The impact of having a child with BPD is really high, particularly in the first year years of life, and patients with BPD deserve a multidisciplinary approach and a lifelong follow-up. And I would like to thank our BPD follow-up team with members of the neonatology, cardiology, intensive care, ENT, and especially Lieke Kamphuis, who is our respiratory physician for the adults. And we have a big supporting team with physiotherapists, psychologists, technicians, and PhD students. So thank you for your attention, and I'm happy to take questions.
Thanks very much, Marielle, for absolutely fantastic presentation. Really enjoyed that. I will have to log off in a second to log into this next session. But before I leave, I want to leave you and audience with two burning questions that I have. The first one is about heterogeneity of BPD. You know, we are now realizing that most of complex disorders in childhood are highly heterogeneous. So your opinion about heterogeneity of BPD, which obviously will have consequences of what would be the subsequent approach to these kids. And the second one, you know, your data is absolutely beautiful on absence of any eosinophilic inflammation in these babies. And yet a lot of them, because of increased probability of wheezing, get diagnosed as asthma and are prescribed inhaled corticosteroids. Now, given all the recent data about alveolization that continues clearly well below age 3 years, what is your opinion about this, and what would be the optimal way to treat these kids once they develop wheezing? Thanks very much again. I really enjoyed this.
Well, thank you very much. Well, for your first question about heterogeneity, you're absolutely right that BPD, like asthma, is a very heterogeneous disease. So why do some children with BPD who are born very preterm do develop BPD and others don't? Some children have really this broncho-obstructive component. Other children more the oxygen need is more prominent. Some other children show more cardiovascular problems, and I think this is clearly caused by the multifactorial origin of BPD. There may be a real difference between children with intrauterine growth restriction versus the children who have a normal birth weight for gestational age. So like in asthma, I think we are proceeding to define phenotypes of BPD. And in the end, I hope we can come to endotypes of BPD. And that touches on the second part. There's hardly any data about the inflammatory process in children who have already developed BPD. So it doesn't seem to be an eosinophilic inflammatory pattern. Oxidative stress seems to play a role. Maybe neutrophilic inflammation may play a role, but we absolutely need more data there. Many children are treated with inhaled corticosteroids, which may be helpful if they also are allergic or they have a positive family history of asthma. But in general, there is no evidence that inhaled corticosteroids in children with BPD does work. We recently summarized the evidence of several treatments in children who already developed BPD, so not on prevention of BPD, but on management of BPD in an ERS task force. And actually for most treatment used nowadays, like inhaled corticosteroids, like diuretics, like bronchodilators, there are no good studies, and we really need these studies. For salbutamol, some children show reversible airways obstructions, and there might be a good reason to put them on salbutamol, but I think it's always a trial of bronchodilators. So you should clearly monitor the effect to decide if you continue with these medications. So Adnan had to leave, but I don't see any other questions in the chat. So I would like to thank you for your attention, and I think we are going to close this live.